My name is Ahmed Mustafa, resident of Dermatology Venerology, Al-Azhar Faculty of Medicine. It's a great honor to be here today presenting Al-Azhar Faculty of Medicine. First of all, I'd like to congratulate Professor Magdi Sheikh, Dr. Ahmed Nuh, Dr. Ahmed Adah for the great... Okay. Okay. As we all know, to reach the final diagnosis of any case, we should take history carefully and in detail. Then we examine the patient, both general and clinical examination. Clinical examination, general and local examination. Local examination or dermatological examination includes skin, and never forget to examine hair, nail, and mucous membrane. And finally, we may need to do some investigation to confirm or to reach the diagnosis. So let's apply these steps on our case today, starting with history. A 5-year-old female patient was admitted in the pediatric ICU and diagnosed as Stevens-Johnson syndrome. Dermatological consultation was needed for painful skin lesions of 4-month duration affecting the face, upper and lower limb of acute onset and progressive course. Let's move to the next step with the clinical examination. As regards general examination, the patient had fever, pallor, enlarged cervical and axillary lymph nodes, and splenomegaly. Dermatological examination showed the presence of lip and gum swelling covered by hemorrhagic crustation. There were purpuric and erythematous papules and macules leaving post-inflammatory hyperpigmentation. There were also ecchymotic patches affecting both lower limbs. Based on the previous history and clinical examination data, our clinical impression was Stevens-Johnson syndrome and Kawasaki disease. Stevens-Johnson syndrome was excluded due to absence of Nikolsky sign, ocular or genital affection. Kawasaki disease was also excluded due to absence of other diagnostic criteria, erythema and edema of palms and sole and conjunctival congestion. Let's move to the final step, which is investigation. As regards skin biopsy, pathological finding wouldn't be sufficient for any diagnosis as the lesions were old. Other investigation showed the presence of pancytopenia, elevated ferritin, serum ferritin, triglyceride, and ESR with moderate splenomegaly. Based on these findings, bone marrow aspiration was recommended. The results revealed mild dysplasia in both myelopoiesis and megakaryopoiesis with increased phagocytic activity. To summarize, the patient had fever, splenomegaly, swollen lips with hemorrhagic crust, pancytopenia, elevated serum ferritin, elevated triglyceride with hemophagocytosis. We searched literature and we found a case with similar findings to our case, known as hemophagocytic lymphohistiocytosis. 5 of 8 criteria must be fulfilled to make the diagnosis of this case. Our case had 6 of 8 diagnostic criteria, so the final diagnosis was HLH or hemophagocytic lymphohistiocytosis. HLH may be primary or secondary. Primary or genetic due to gene mutation, usually affect infants or early childhood, while second or acquired, more common in older age. Treatment of HLH, the first line includes cyclosporin and IVIG, and bone marrow transplantation may be needed in persistent disease. Our patient received treatment in the form of IVIG 1 gram per kg per day for 3 consecutive days. And this was the result after 2 weeks of treatment. And finally, the patient was referred to Nasser Institute for bone marrow transplantation. Thank you.